Good evening, everyone, and welcome. Thank you for joining us for today's webinar. My name is David, and I'm the chapter co-chair of CSHP Golden Horseshoe chapter, and I work at Norfolk General Hospital. We're going to start shortly, and then recognizing that there will be more people joining us. But here with me are my chapter co-chair Gunther, our presenter for tonight, Dr. Andrew McIver, and our sponsors from ASTRAZeneca, who really made this webinar possible. So today, Dr. McIver will be presenting on reframing asthma care. Just a little housekeeping before we get started. All participants will be muted, but if you have any questions during the presentation, please type them into the question or chat box in the GoToWebinar control panel, and I will be monitoring and then bringing them up at the end of the presentation. Now, without further ado, we will turn our time to the presenter. And Dr. McIver is originally from Belfast in Northern Ireland. He qualified with an honors degree in medicine from Queen's University, Belfast in 1984. After completing his postgraduate training in internal medicine, he immigrated to Canada in '89. He trained in respiratory medicine at the University of Toronto and obtained a medical research council grant to study in clinical epidemiology at McMaster University, where he spent time working in the field of obstructive lung disease and obtained his master's degree. His major clinical and research interests are knowledge translation in asthma and COPD. He's the author of more than 100 scientific papers. He has just completed a 5-year term as chairman of the Asthma Committee of the Canadian Thoracic Society and as an examiner in respirology for the Royal College of Physicians and Surgeons Canada. At the present time, he is a professor of medicine at McMaster University and staff respirologist at St. Joseph Healthcare Hamilton. Dr. McIver.
So thank you very much, David, and other organizers and colleagues, and Heidi, my local specialist rep. It's a real delight to speak with you tonight. I hope you can all hear me clearly, and I hope you can all see the screen in front of you. And if you have any problems, just send a little message along. I think I really do appreciate you taking the time tonight. Hopefully you're all sitting comfortably at home, relaxing with a coffee or a wine or some dessert. I think we're all getting a little bit of fatigue this weather because of COVID and the restrictions, and also the fact that we're having a lot of these Zoom meetings, but I think they are really progressing, whether they're WebEx or Zoom or whatever. And I think they may be the way of the future for a lot of CME. So we'll have to develop content further for these. Tonight, it's really nice to speak about reframing asthma care, because this is a time that we are keeping in contact with a lot of our patients. We're doing wellness checks, we're renewing a lot of prescriptions by phone and by fax. And thank you very much for helping us. We have a couple of overseas students who in their countries, they're not allowed to do such things. But for us, it's been very, very useful. And thankfully, as you know, being a specialist, I have a limited number of prescriptions and medications I write, predominantly renewing inhalers rather than some very complex regimes of the other medications that the patients are on. But I do some medicine from time to time. So thank you all for taking our calls and listening to our messages. So tonight's event is sponsored by ASTRAZeneca. I have updated these slides a number of times, but I've worked with nearly every pharmaceutical company that's been involved in asthma, COPD, smoking cessation, and but tonight's event is sponsored by ASTRAZeneca. I have done research and clinical trials. I've helped develop some slide kits, and I've also given a lot of these presentations. And I'm sure if I saw a lot of you, I'm much better with faces than I am with names. So when we put together such slide kits, we really based it on guidelines. We use the Canadian guidelines, we use GINA guidelines. We, of course, use evidence-based medicine, and the recommendations are evidence or guideline-based. And then, of course, the whole thing about this is to keep them very pragmatic and practical. And what we hope to do with events such as tonight is to bring these to life. And these slides are a very nice set that are put together after a needs assessment and by people who you'll know very well. Mark Fitzgerald used to work at the Firestone many years ago, but he's been in Vancouver for maybe 25 years. Alan Kaplan's a very prominent primary care physician in the Richmond Hill area. Harold Kim, you may know, does some asthma and allergy more towards Kitchener, Guelph and down towards London. And Paolo Renzi's an excellent colleague in Montreal. So one of the things we're really going to focus on tonight is, and I'm sure you've seen it because even recently, when we are managing asthma, asthma is an inflammatory condition. And when someone has a diagnosis of asthma, we need to treat the underlying inflammation. In very mild cases, perhaps in kids with some allergies, we can use leukotrienes, which are a non-steroidal anti-inflammatory. But even evidence from Francine Ducharme shows that regular use of a very low dose inhaled steroid is the anti-inflammatory of choice even in children, although there may be compliance issues between taking a low dose inhaled steroid and using leukotriene. But in adults, the foundation treatment, once I had someone that is diagnosed as having asthma, they all will leave my office on anti-inflammatory treatment. And the cornerstone of this, particularly in adolescents and adults, has been a low dose inhaled steroid. Recently, the guidelines have evolved. And what I say is if a low dose inhaled steroid is not working, and the patient is still having symptoms and exacerbations, we no longer increase the dose of inhaled steroids. We check compliance, adherence, and we check technique, we check device, and then we switch them to a low dose ICS-LABA combination drug. All the time, the use of a Ventolin or salbutamol inhaler is used as a marker of being uncontrolled. It's a reliever medication. And the biggest change in strategy that we have had that has been endorsed by guidelines both nationally and internationally and by many of our sister countries has been the evolving role of Symbicort as an ICS-LABA. The LABA formoterol has a rapid onset of duration of action and a long duration of action, and the inhaled steroid is a very safe, effective inhaled steroid. So a series of studies chaired by my department boss, I was the site lead for the Firestone Clinic, but Paul O'Byrne and Mark Fitzgerald wrote these studies, evolved a treatment that was initially called SMART, of Symbicort maintenance and reliever therapy, to talk about STHMA, and STHMA stands for SY, Symbicort, G given, and MA, mild asthma. So what I'm really going to focus tonight is to Ventolin is overused and abused by patients. The paradox is that patients frequently will use this as their only medication. And we've seen that recently when in this health crisis we've had, there was a shortage of Ventolin. In fact, we would wish people to not need as much Ventolin, but to be much better controlled on their asthma. And we'll talk to that a little bit. And specifically around COVID, all of the medications work well. The most important thing to do for an asthmatic patient is to control their asthma, because if they're coughing and wheezing, even if it's not COVID, there's going to be lots of people around them that are going to be very upset because they're going to be concerned about this as we move into the fall. So just to let you know, all asthma patients, even patients with mild asthma, are at risk of severe life-threatening exacerbations. So we did a study many years ago at the Firestone that took asthma patients in Hamilton that were deemed not to need any controller medications, just PRN Ventolin, and we put them on low dose inhaled steroids, and we showed over a 1-year period 200 micrograms of inhaled steroids reduced hospital admissions, hospital visits, and oral steroid use by 50%. So asthma, we know, is not a fixed disease, not like blood pressure where you progressively increase until you're happy with the level of control. Asthma varies by time of the day, by time of the month, by time of the season. If you go to your grandparents who have a cat and you're allergic to cats, the asthma will vary. So it is important to have a good maintenance regime and then to have a regime that is flexible. So new evidence demonstrates how the choice of an anti-inflammatory reliever can improve the outcomes. How many patients are at risk for exacerbations? Well, this is some data taken from the British Thoracic Society, and this looks at children and looks at people with mild, moderate, severe, very severe, just different types of categories. Looks at adolescents 5 to 17 and looks at adults. And you can see right the way across the board, just as I mentioned earlier on, about a third of patients with even what we consider to be mild asthma are still at risk of severe exacerbations. And one of the things about this is when a patient is having problems, they usually reach for their Ventolin and take some more of it. Just to remind you, as I've said earlier, Ventolin is not an anti-inflammatory treatment and does not treat asthma, it relieves symptoms. So let's say, for example, you're in contact with a cat and you take your Ventolin reliever, it opens your airways up, and what happens is you actually get more cat allergen in, your airways are trying to protect themselves. So then your lungs get tighter and you need to use your Ventolin again. And then about 4 hours later, you get the late asthmatic response, which is the influx of eosinophils, which makes your lungs tighter again, and you need to waken at nighttime and take some Ventolin. So the whole concept behind this is with a Symbicort. Symbicort is Pulmicort as the inhaled steroid, and then Formoterol as the LABA, but it has a rapid onset and long duration. So like Ventolin, it immediately relieves the symptoms and has a long-acting activity lasting for over 12 hours. And with a tiny amount of inhaled steroids, what you're giving the patients when they use Symbicort as a rescue medication is immediate relief, long-acting relief, and a tiny amount of extra inhaled steroids to treat the inflammation, which is what asthma is. So although there's bronchospasm, the driving factor is inflammation. And you can see this is even more prevalent in elderly patients. What are the risk factors? Well, as I mentioned already, no matter how you're treated, if you're not taking your prescription, if you're not using your device right, if you're not complying with your regime, that asthma is not going to get better. Again, we know to monitor overuse of Ventolin. In fact, a Ventolin inhaler should have 200 puffs in it. So someone should only need one Ventolin inhaler per year, because using control would be 3 puffs or less per week, 52 weeks in the year, 150 puffs. And although people will keep a Ventolin inhaler in the cottage or in the car or whatever, once you've saturated that system, the patient should not need extra Ventolin. But how many times do we ask a patient, they say, do you need any repeats of your prescription? Do you need your Symbicort? Do you need your Advair? Do you need your Flovent? They say no, but can I have an extra couple of Ventolins? Comorbidities such as allergic rhinitis, GE reflux can make asthma worse, allergen exposure. Lots of our patients, unfortunately, still keep their cats at home. They're exposed to secondhand smoke. There may be pollution in the air, particularly in the industrialized cities. Socioeconomic problems, low lung function, having a high eosinophil count or an elevated FeNO, a test that we don't do as often, but we're hoping to do a little bit more. History of intubation or ICU being a risk factor for severe or life-threatening asthma. And of course, one or more exacerbations. And we did a study showing that lots of patients in Canada consider their asthma not to be something they need to take a controller on a daily basis, but something they take medications whenever they feel bad. And if they get worse, they go to the Emerge or the walking clinic once a year and require a course of oral steroids. That's not how we perceive it, because oral steroids are life-saving and disease-modifying, but they are a drug that is fraught with the potential for side effects long-term, even from short courses given to patients. So this is another study that looks at adherence, because you would think that regular use of an ICS LABA would be very good. But in fact, many studies have shown that there is considerable drop-off from the regular use, that people do not believe. And in one study of even Advair Discus twice a day, only 13% of patients that were initially compliant with a twice a day regime were compliant at the end of a 1-year period. Because the concept is when they feel good, they do not feel their asthma is active or even quiescent. What are the consequences of patients remaining at risk for exacerbations? Well, again, there's increased likelihood of severe attacks, requirement of oral steroids, increased healthcare utilization with ER and hospitalizations. With asthma exacerbations, there's inflammation, and the inflammation can actually cause some fixed airflow obstruction. That's why we use the concept of airway remodeling. Prednisone, as we've already mentioned, is not without acute and chronic side effects. Asthma mortality is still an issue. There's reduced patient quality of life. And again, it costs more to the healthcare system. Of course, some patients may say, being penny wise and dollar stupid, that oral prednisone only costs me a small amount of money compared to a regular use of inhaler, but that is not good medicine nor what's acceptable in Canada as medication. Now, when we look at costs, of course, when we start to talk about millions and billions, it's really beyond what we can perceive. But again, there's lots of costs, both from the direct costs and indirect costs of time lost off work and wages. And there's some nice and elegant studies both published in the Canadian and American literature due to this. One of the paradoxes within asthma management, that, so the first paradox is, in the older guidelines, step one was diagnosing someone with asthma and just having them take a Ventolin or salbutamol inhaler whenever they needed it. As I've already said, that's not something that happens in my practice. Patients with a diagnosis of asthma, so they have a clinical diagnosis, and in adults is confirmed with an objective test, leave my office an anti-inflammatory treatment. That could be in a very young child, a low dose leukotriene. In most children and adults, it's a low dose inhaled steroid. Again, in step two, what we do is we then put in an inhaled steroid as a controller medication, but we ask them to still monitor their SABA use as a rescue medication. So as I've mentioned, that now what we've been doing is using an ICS-LABA as their switch treatment, and the ICS-LABA they've been using most of has been Symbicort. There's no doubt, before anyone asks, Zenhale does include formoterol, which could have the same potential as use in Sigma or in SMART as Symbicort, but it has not done those studies, has not been approved by Health Canada for this, and be what's called an off-label, particularly because the device is different. Most people take 2 puffs from an MDI, whereas they take 1 inhalation, or are quite happy to take 1 inhalation as an extra or rescue dose when they're using a Symbicort turbohaler. So again, patients need to understand asthma is an inflammatory condition. We're treating the inflammation. I sometimes use the analogy of air conditioning, whereas the rescue medication is a bit like a ceiling fan. And if on a hot summer's day, you could not leave the ceiling fan on all day or night, it will burn out. You need, neither can you get air conditioning installed, because they will say, we're busy this year, come back next year. So there has been a little bit of concern over the years with the use of long-acting beta-agonists on their own for asthma, particularly that of salmeterol, which is part of Advair. There's been no safety concerns with formoterol, which is what's part of Zenhale, or of Symbicort. But sometimes patients can get confused over use of medications. Overuse of short-acting beta-agonists is a problem. Appropriate use of long-acting beta-agonists, particularly combined with an inhaled steroid, is not an issue. Although the only one that you have the flexibility to go beyond the 1 inhalation twice a day or 2 inhalations twice a day is the Symbicort device. Again, patients do need education. Any leaflets, any posters from a certified respiratory educator, from the pharmacist, from the GP, from allied health professional, it is important to take those educational moments. Patients over-rely on rescue medications and under-rely on the controller medications. This is some data that shows there is a window before someone has an exacerbation. But as I mentioned already, if during that window all they do is take more Ventolin, it really won't do much different. However, if in that window they're using the SMART Symbicort maintenance and reliever, or the Sigma approach, that the patients, when they take a reliever, when ICS-LABA Symbicort is used as the reliever medication, this will ablate and attenuate, or make the exacerbation not happen or be as severe, because they're able to blunt that exacerbation. Now, this is some data. This is Sami Suissa from Montreal's data that shows that if patients are using significant more Ventolin, there's an increased amount of asthma mortality. So we do have to be very careful. Of course, there are some individuals, it's hard to tease out whether it's asthma or COPD. Those COPD patients that tend to use a bit more Ventolin than we would be concerned about for an asthmatic patient. And also, Sami Suissa published from the Saskatchewan database that if we can reduce their salbutamol, but also increase the amount of inhaled steroids they're taking, to actually get them to take half of what they should be. Usually it's about a canister a month they would be using. If we can take half of that, we can reduce mortality of patients with asthma. So this just looks at the more canisters of SABA they use, the more likely they are to have exacerbations or visits to the emerge. So regular or frequent use of short-acting beta-agonists, the most common one, of course, being Ventolin, decreases bronchial protection, causes rebound hyperresponsiveness, decreases bronchodilator response, and increases the allergic response and increased eosinophilic airways. Higher use of SABA is associated with a 45% increase in the risk of asthma-related hospitalization and a 25% increase in the risk of emergency department visits. So current reliever strategies, that reliever controller, has really been a difficult paradigm to shift. And as I say, guidelines, both Canadian guidelines and the GINA, the global initiative, have now upgraded to show inhaled steroids being the foundation of treatment, and very quickly switching to using the ICS-LABA as the foundation treatment or as a very suitable rescue treatment rather than the rescue of using a ventolin. And the answer is, could this happen? So this is some data taken from a study that was reanalyzed and showed that when you look at the time to first serious asthma-related event, that patients that compared to being on an inhaled steroid, placebo patients were having more symptoms. So again, if a patient's having symptom and they're taking a rescue Ventolin, it's only relieving the symptom and not identifying this as a warning sign that their inflammation of asthma is starting to be active. And as this increases, been able to attenuate it. What's the evidence that use of a ICS-LABA, such as budesonide formoterol, as an anti-inflammatory reliever in therapy works? Well, this comes, as I mentioned, from the STHMA database. And STHMA again stands for Symbicort, SY-G, given in mild asthma. And this is a strategy that is unique to Symbicort that allows you to have a patient use Symbicort on really a PRN basis. So people with mild asthma, they may not need to use something year-round, but they can take Symbicort when they have a symptom. So we take the Ventolin away. This is an evolution of the strategy that many of you have known over the last number of years called SMART, where SMART was you picked a maintenance dose, Symbicort 100 or 200, once or twice a day, 1 puff or 2 puffs, and then you take extra doses of Symbicort up to a maximum of 8 per day, which happened very, very infrequently. And this was a very important strategy to optimize control of asthma. Now this has evolved into even the patients with type 1 or type 2 or A or B or mild or moderate, that again, you can give PRN Symbicort only to your patients, or you can use the Symbicort and as the rescue medication for those individuals. So STHMA 1 and 2 were studies done under regulations of the FDA. One of them was a little bit more rigorous. The more rigorous study had a placebo-controlled. The rescue medication they used was terbutaline Bricanol. So this compared placebo versus and terbutaline as rescue, compared to placebo twice a day, using as needed, basically Symbicort, and then maintenance of 200 twice a day of budesonide Pulmicort, and as needed terbutaline. So, and this study was very carefully monitored. It had a placebo arm, and the primary outcome was well-controlled asthma days. And the second study was a little bit more unique. These patients were on placebo twice a day, but used PRN, Symbicort, or else a low-dose inhaled steroid twice a day, and as needed terbutaline. In the first study, all patients received incentive reminders. So twice a day, they got a text or to their phone telling them or reminding them to use their regular. So this was when patients were using regular medications. If you look at STHMA 1, that this looks at adherence, even in a clinical trial, even with incentive reminders twice a day, patients that were supposed to take regular controller medication only did that 80% of the time during the 1-year trial. In the STHMA 2, where there was not the incentive reminders, the compliance rate over the year was around 64%. So 25% didn't take it in STHMA 1, and a third didn't take it in STHMA 2 on a regular basis. So when we looked at the outcome of the STHMA 1, it showed no difference between the group of patients using as needed terbutaline and as needed formoterol, that in the odds of well-controlled asthma weeks, which is the primary outcome. So, sorry, this was a 14% decrease, which just made the p-value. it was non-inferior to the regular inhaled steroids. And however, if we looked at the PRN Symbicort versus the as needed salbutamol, you could see there was a 64 reduction, a highly significant value. So what this study showed was that if you used as needed Symbicort, it was far better than as needed rescue medications. Low dose inhaled steroid was a very effective regime to manage people, but compliance rates were low even in the randomized controlled trial. And this looks at the group that were receiving sigma 1 on the left-hand side, receiving the PRN terbutaline and CSHP compared to the control that was achieved for the regular inhaled steroids or the PRN Symbicort, and that was the same in the sigma 2, the control achieved with the regular. So you may say, well, hey, what are we really talking about then? Because if I do the old regime, which is giving my patients low dose inhaled steroids, that's going to be fine, which it is. But let's look at the amount of medications used. So in sigma 1, if you may remember, patients were using their budesonide 200 twice a day, but in 80%, they were only taking 80% of the time. So they got the same amount of control by using 340 micrograms on average of inhaled steroids a day. However, one of the major reasons people don't take their medications is because of worry about long-term exposure to inhaled steroids. The same benefit, exactly the same benefit, was when patients took their Symbicort on a PRN basis, and they used that so the average daily dose of inhaled steroids was only 57 micrograms, there was an 83% reduction. When you looked at the patients in the sigma 2, you can see that compared to the Symbicort PRN, in this case, the budesonide 400, 200 twice a day, they only took it about 64% of the time. So 64% of 400 is around 270. In this case, a similar value was used for the PRN of 66 micrograms, a 75% reduction for the same outcome. So if we want to gain the appropriate amount of control and reduce the exacerbations and also expose patients to less, this new strategy of using Symbicort as the reliever medication is a very, very effective strategy. So again, using Symbicort as needed was inferior to Symbicort maintenance twice a day on well-controlled asthma weeks. However, this came at the significant reduction of the exposure to long-term inhaled steroids. Now, again, on people on regular inhaled steroids, the budesonide group had a slightly higher increase in lung function, but again, that was the cost of the extra inhaled steroids. And again, if we look at the patients, this was patients using 2 or more needed inhalations compared to 4 or more inhalations. There was not that great a number of patients. So another study that's worthwhile looking at is a study where they used the more traditional rescue medication. This was salbutamol, 2 puffs as needed. Do you remember I said earlier on, most people when they use a rescue MDI tend to take 2 inhalations, not 1 inhalation. And this was a proper double-blind randomized controlled trial. The patients were on Symbicort, 1 inhalation as needed. They were also third arm that had the budesonide Symbicort 200, 1 inhalation twice a day, and they used the salbutamol as the rescue medication. So again, comparing this new strategy of Symbicort PRN compared to the old strategy of PRN salbutamol, and then the controller medication of the low-dose inhaled steroids. And you can see again, compared to the PRN salbutamol, annual exacerbation was much less in the group on the inhaled steroid or the Symbicort on a PRN basis. Again, a slight benefit towards the regular inhaled steroid in the annualized exacerbation rate. But if you look at the number of severe exacerbations, again, the biggest benefit was on the Symbicort group in reduction of the severe exacerbations. And again, the Symbicort group met fewer exacerbation criteria versus the short-acting beta agonist group. You can see on the left-hand side in green, the salbutamol group. The middle group is the budesonide maintenance group. and the right-hand group being on the Symbicort. How have asthma recommendations evolved in response to this data? So the major change in GINA, and GINA have published this, and they have actually had a really nice editorial to give you the reasoning behind this. But they say now that adults and adolescents with asthma should no longer be treated with a SABA alone, whether that is Ventolin, whether that's salbutamol, whether that's Bricanol. Instead, they should receive either symptom-driven and mild asthma as needed Symbicort, budesonide formoterol, or regular low-dose inhaled steroids to reduce the risk of exacerbations. They say that low-dose ICS formoterol as needed is recommended as the preferred controller for step 1 and preferred reliever for all degrees of severity, right the way throughout the spectrum. Because remember, a more severe patient who's using an inhaled steroid twice a day, same scenario. If they start to use Ventolin as their rescue, it will not give them extra anti-inflammatory control at a time they crucially need it. And this is the schemata. I know you're extremely familiar with it. I know there's a lot of information here. But what you can see is in this, GINA talk about steps, step 1 on the left-hand side, step 2, step 3, step 4. They try and have the steps big to show the vast majority of people have step 2. And now what they're seeing is right from the very extreme, you can see that as needed low dose ICS formoterol that specifically stated this, and the only drug with an indication in Canada for this, the only combination is Symbicort, as per the STHMA trials. And as you can see right the way along the bottom, the preferred reliever is as needed low dose ICS formoterol, that is the Symbicort as that. And this is for 12 years of age and above. And I'm sure if you haven't, you can download GINA. There are slides. There is other information. And if you haven't seen the editorial or the information from the STHMA trials, I'm sure Heidi or others would love to drop that off with you. Why has GINA changed? Because again, they are very dynamic. They're a very resourceful group. They have a lot. They meet at least twice a year, and they update their guidelines every year. This is a huge undertaking and takes a lot of resources, because sometimes people say, why aren't the CTS doing that? Well, when I did it, it's a very laborious task and takes a lot of resources, and then you get diverted because of life, because of your practice, because of COVID, because of other things. So the reason they've done this is to improve patient care, to reduce asthma-related exacerbations, including death, and even for patients with mild asthma, where these should not be ignored or lip service paid to provide a consistent messaging about the aims of treatment, and not just to take a reliever when you feel like it that does not treat the underlying asthma, and to avoid establishing a pattern of relief, because lots of patients all at some stage have relied solely or frequently on their Ventolin inhaler. So some of the questions, is formoterol as fast acting as salbutamol? The answer is yes. There was a study I constantly quote people in the emerge department that FEV1s were around 44% randomized to receive formoterol via the dry powder inhaler or nebulized Ventolin salbutamol at high dose, and it showed just as quick, if not quicker, improvement in FEV1 with formoterol, but less tachycardia and less shifts in serum potassium, which can occur with nebulized Ventolin. These are tornado or forest plots that again look at some meta-analyses that have been done. And no matter what way the strategy of SMART or STHMA have been looked at, the strategy always favors the relief using the ICS LABA maintenance therapy of budesonide formoterol. Again, a very, very busy slide, because I say the as needed mild STHMA studies and the SMART studies, which have been around for a number of years, have constantly shown a significant benefit, whether that's compared to the same dose or a higher dose of inhaled steroid or a competitor combination product such as Advair. So very, very nice data. You're giving the right medication at the right time. You're not over-treating during months where the patient's disease is not active. You're responding to the variation of asthma. And when a patient needs it, you're not just relieving symptoms, you're relieving the symptom and treating the inflammation, which is eosinophilic. the present time, budesonide formoterol is the only anti-inflammatory reliever indicated for use in patients with mild, persistent, moderate, and severe asthma. So we've whisked through that very quickly. I hope I haven't gone too fast, but we have lots of time for questions, and perhaps you can start writing those in for your chairperson. But many asthma patients remain at risk for exacerbations due to over-reliance on SABA treatments such as Ventolin and poor adherence to their controller medications, whether it's an ICS monotherapy or whether they had switched to an ICS-LABA combination therapy. Budesonide formoterol in a single inhaler known as Symbicort in Canada as a dry powder inhaler simplifies asthma management and improves outcomes across the spectrum of activity. In mild persistent asthma, I've extolled the virtues of the Sigma Symbicort given in mild asthma, and in moderate to severe asthma, I've also highlighted, but only briefly, talked about the studies for SMART, Symbicort maintenance and reliever, which you've heard about, I'm sure, multiple times over the last couple of years. So this is a strategy which we have adopted in our day-to-day practice. It's in keeping with current Health Canada policies, it's in keeping with our Canadian guidelines, and it's in keeping with GINA guidelines. So there is no more pleasure that throughout my my career, when I started in the qualified in the mid 80s in the UK, we were using Pulmicort and Bricanol very significantly. When I came to Canada, Pulmicort was just being launched in 1989, I believe. Beclovent, low dose inhaled steroid, Beclofort, high dose inhaled steroid were mainly used. Then we saw the evolution of the ICS-LABA combination drugs, which I have done lots of research on. And now again in Canada, we have the evolution of the biologic treatments, which we're not talking about tonight, the anti-IL-5s, the soon-to-come anti-IL-4s and 13s, and many other exciting products. So things are changing and evolving very nicely over a number of years, but also the strategies have evolved from the use of reliever to reliever and controller, and now a drug that all in one can gain control, maintain control, prevent and treat an exacerbation, relieving symptoms and treating inflammation. So COVID and asthma and CTS, just to remind you, there does not appear to be increased risk of COVID for asthma patients. The primary goal, of course, remains to control asthma. Optimal control is best protection. And there's even data, as you may have heard in the last couple of days, about the benefit of steroids, particularly Decadron, in the treatment of acute COVID. And we have used some steroids in our patients at the Firestone. And I do think that this is a crucial thing to remind patients to stay on their regular medications. I am encouraging all my patients to get their flu shots, my more severe patients with asthma to make sure they've had their pneumonia shots as well. And hopefully we will get through this all together. So I'm going to stop there. The last slide just says, continue your controller medications during the pandemic. Oral steroids should be used to treat severe exacerbations. That no clear clinical evidence of harm from corticosteroids. And in fact, as I said, benefit from a study that I don't think has been actually published, but it certainly has hit the press. I think Monday morning of this week from the UK. Patients should remain on severe asthma biologics. I have no problem with that. And again, nebulizers, we really don't use them very much in Canada. I've never taken a nebulizer away from a patient, but it would be extremely rare, and I have not prescribed one in 30 years for a day-to-day asthmatic or Ventolin or asthmatic or COPD patients. I think it's brought further to view this fact of being aware of why are patients needing a lot of Ventolin. If it's for asthma, they should be seeing their physician. We always do need to help patients out, but overuse of Ventolin is a trigger. And unfortunately, a lot of these patients don't come to regular appointments, and they abuse, they walk in clinics, or they don't come back from the emergency departments. It's a good chance to reassess asthma control and management. SABA is a reliever medication, but as I say, it's been usurped now from the evidence I've shown you. It's worthwhile bringing it up with patients. Remember, a Ventolin inhaler has 200 puffs, and again, there are limitations on the use of the devices. So I'm going to stop there. I don't think we need any further slides unless there's a question related to it. So I have it about maybe 20 minutes too. So we have plenty of time for questions. I see there's about 26 people online as well as the faculty. So please, we'll open it up. Type in your questions and I'll hand it back to the chairman to guide this part of the talk.
Thank you, Dr. McIver. We'll go ahead and take some time for questions. And then just a reminder, please be sure to type your question box in the control panel. And to start us off, I was just wondering if you can explain the potential mechanism or that was driving the sort of significant reduction in severe exacerbation when comparing Symbicort PRN to regularly dosed low-dose ICS.
Well, I think the strategy is, yeah. So I think that low-dose inhaled steroids are still a very, very effective regime of medications, but it comes down to compliance. We've seen here in 2 randomized controlled trials, even one with incentive reminders, compliance was dropped off. It was only 25% over a year in patients who were deemed to be compliant with appropriate technique, and on the other one, a third of patients or more did not take their medication. So what using Symbicort does, it allows people to be a little bit more in control of their disease and control of their. So let's say the problem, we don't talk about drug holidays, but one of the common questions I ask people is, your asthma better in the summer or better in the winter? And they tell me it's better in the summer, and I haven't seen them since last summer, and they tell me the winter went superbly. I don't reduce their medications coming into the summer because then they're going to flare. So I think there's a very much more dynamic. It allows the variability of asthma to be entrenched into their management regime. Otherwise, the old data from the early GSK trials were put everyone on very high dose Advir and leave them there, and they will not have any they'll not have any exacerbations, nor will they need to use an action plan because they won't have exacerbations. But of course, the concern is many of those patients will be over-treated. So the whole point of the Symbicort as your rescue, whether it's SMART or Sigma, is you're giving the right amount of medication at the right time. And it does not seem that patients overuse or abuse the medications. It's extremely rare, even in clinical trials, that patients would increase their dose to anywhere near the total of 8 inhalations in a day. So the analogy I sometimes use is that the older fixed regimes are a bit like, I used to have an old Volkswagen that had over 350,000 kilometers on it. It's a bit like you only have 3 gears, and you can drive around with your foot flat on the accelerator all day, which is your maximum dose of LABA, and you can stop at a gas station or pharmacist to change from first gear to second gear to third gear, such as the Discus 250 of Advir, the 100 or the 500. But the Symbicort is a bit like the sequential manual gearboxes you have in the new BMWs and the Mercedes, that every time you put your foot down the accelerator, giving yourself more beta agonist, you're getting a gear change, or every time you change the gear, you're getting a composite change in that. So they're very flexible. And this flexibility is really what asthma is. Asthma is not a fixed airflow disease in time or in season, if that makes sense.
Great, thank you. Yeah, and then a question is, are there any studies looking at the role of Symbicort in patients who are currently hospitalized due to an acute exacerbation?
No. The traditional regime would be, if we see someone in the emerge, it goes back to Rick Verbeek's paper in New England Journal of Medicine, we give them steroids, so that golden hour. We continue in our guidelines, and I was the first person who actually wrote a guideline of how to manage asthma in the emerge or in the hospital, which are part of the CMAJ. You can put my name in, and there's 7 case-based scenarios that we have put there. Generally, in the hospital, we give them steroids, and usually it's oral steroids unless their GI tract isn't working as quickly, either 125 a sodium hydrol IV or 50 milligrams orally as soon as they get there. And then we give them maximum bronchodilators that we can. We do continue their regular inhaled steroids. So I will increase their Symbicort to 2 inhalations 4 times a day. I will perhaps give them extra inhaled steroids. We'll give them oral steroids. We'll give them perhaps magnesium if they're very sick. And then we monitor them. and then we make sure it's not some other condition. Do they have pneumonia? Do they have a virus? More so rhinovirus causing a lot of problems, GE reflux or whatever, exposure to cat or other allergen. And usually those patients will settle. We've had a couple of bad asthmatics ventilated this year. I just got a call last week when I was on call about a bad asthmatic who was even on a biologic who was ventilated up in Sudbury. So that's our standard approach, is to maximum broncholytic, supportive care, and then steroids on top of that. And it wouldn't bother me whether they had COVID or not. I would still give them the steroids.
Great, thank you. And if an asthmatic patient who is stable on an ICS-LABA combo is not put on daily oral corticosteroids long-term for another condition, would you stop the ICS and switch to only LABA?
No, but good question. So inhaled steroids work totally different from oral steroids, and as I mentioned, even during exacerbation, I had an old boss who wasn't a respirologist, but always stopped inhaled steroids if there were oral steroids, but they work totally differently. And although people have this thing, inhaled steroids take 10 days to work, there are cellular changes that are within minutes and seconds, such as their vasoconstrictors. That's how you work out the dose of steroids, it's vasoconstriction. So in general, that's important because it stops edema in the airways, increases the diameter of the airways, and stops influx of eosinophils. So they work differently. For someone like that, I allow the other doctor to mark them up. I would never prescribe a LABA on its own. That's a unique situation you give me, but I never prescribe a LABA on its own. It needs to be combined in the same inhaler. So I do not use Ceravent, I do not use Formoterol in an asthmatic patient. Slightly different in a COPD patient, but usually in a COPD patient, our first go-to medication will be Spiriva in Canada or tiotropium. And then usually we're using a lot of dual bronchodilators, and then we're using triple therapy still. So I do not really use, nor have ever prescribed a Ceravent or Formoterol to an asthmatic patient alone. There are very, very certain nuances on my colleague, our ex-colleague, Freddie Hargreave or Param Nair may use certain nuances, but those are very, very unique patients. And I think it's only asking for trouble. So no, I would continue them on an ICS-LABA controller. I may reduce the dose. That would be an ideal patient to put on Symbicort with Sigma or Smart, because I know they're going to do well or whatever, and they do work differently.
Thank you. The Ontario Drug Benefit Limited Use or LU code for Symbicort states that patients have to be on an optimal anti-inflammatory treatment and still experience symptoms. So how do you get this medication covered under ODB if you're initiating?
Yeah, the criteria, there is a little bit of a lag behind what is being approved by Health Canada and what the ODB criteria are. I would say that in my practice, I do not see as many people in that very mild part of the spectrum. Certainly for the approach in SMART, I believe the LU code of 330 is totally appropriate. Perhaps you could say if it was the sole preventer that may not meet the criteria. I must admit that that may be a slight dilemma, but I think the alternative would be, so I've carefully documented in my chart that if it was not for this strategy, this patient will be in a regular low dose inhaled steroid at a higher dose. At the present time, I'm advising that the Symbicort could be used that way. And I would hope that my peers, if that was audited, would be, but it would be a more unique situation. I'm not suggesting that everyone is going to throw away every ventral inhaler. And my proviso is there are lots of people out there, and we've done some studies on it, that have a label of asthma and do use some Ventolin that do not have asthma. Okay, that's why I say a patient leaving my office where I have a clinical confirmation and an objective test that confirms it, they do not leave on just PRN Ventolin. So I have someone with asthma that I'm picking a strategy about. And I did ask the same question of AstraZeneca, and they are working, of course, with the government to make sure no one would fall foul of any particular loophole. but I think that will be a rare situation. But I do appreciate how we all have to be the guardians of this. But I think the data is there that this will be a much better strategy or treatment.
Great. And this might be a question/statement. So GINA diagram shows that the budesonide formoterol is the reliever of choice for all steps, but the GINA 2020 guidelines clarify that it should not be used in patients on other ICS LABA maintenance regimens. Reliever for those patients is still ASTHMA. There was some confusions when GINA 2019 came out. We're just wondering if you can.
Yeah, so I think this is obviously the pushback or the concern. No one's done a study to say if you're on Advir twice a day, say Advir, you're going to be an Advir Discus 100 twice a day, and you could actually still use Symbicort for rescue. These are only strategies; they're not really guidelines. But I think it's really that pushback or that confusion of patients, because I think the whole concept is, and I think we have all seen patients that say they have actually taken more of their Advir MDI or their Discus than is in the product monograph. Those, again, patients who don't take the Zenhale or Advir regularly, but take more of it when they feel a problem, are people who should be, just like that last code, they are definite candidates to go on to Symbicort Smart or Symbicort Sigma, because they're actually willfully doing, and those other strategies only work if you use them regularly. So you cannot take more because you're pushing yourself into the toxic level of certainly the salmeterol. That so I think those are to get around those criteria. There's some individual variation in how those are interpreted, but that's the real regime. Is they're saying is the caveat is that we really do feel that the ICS LABA formoterol is the go-to rescue of choice, but the caveat is if you're an Advir 500 twice a day, perhaps. Now, in acute exacerbation, again, you're trying to maximally bronchodilate them, get the steroids into them, get whatever works. I think there's caveat. And the one I do encourage you to look at, if you haven't, there's a great Australia-New Zealand guideline that actually, it also has a caveat that in Canada, I believe Symbicort is limited to 8 inhalations a day, whereas formoterol is limited to 12 inhalations per day. Whereas in fact, the limitation on, that doesn't make any sense, because the limitation is on the LABA, it's not on the inhaled steroid. And in the Australia-New Zealand guidelines, they have a superb action plan that even says, if you're calling the ambulance, take more of the, if it's your asthma, take more of the Symbicort until the ambulance comes. Don't stop at the 8 or 12, but that's not what is our Canada allotted one. You know, you always get these things. You know, my doctor told me to take 50 puffs of my Ventolin. You know, that are someone has made an individual partnership with a patient. That may be the thing that works for them, but we can't put that in the guideline or strategy. So you're exactly right, and that was an update. But if you read some of the couple of editorials from Helen Riddell, she's tried to explain why that rationale is there. So that's not science-based, it's based on just a practical interpretation of what would happen.
Great. Is there a concern that certain patients may not be able to use the dry powder inhaler Symbicort device? Was it because of inadequate inspiratory effort? Was it touched upon in any of the studies? And if so, is there a way to screen for this and use MDI plus aero chambers instead?
Yeah. Well, some of the countries do have Symbicort and an MDI. The US does. We don't, unfortunately. But just to remind you that this used to be a dilemma where, let's say, not to pick on things, but let's say AstraZeneca were one of the first companies to go with dry powder inhalers. Some other companies, such as GSK, didn't have them at that time. So you were picking companies opposed to devices. The whole world really changed, because a lot of people used to say that if my patient doesn't have enough suck, they're not going to get the medication in. Also, they'll say if my patient has bad COPD or has a really bad asthma attack, they're not going to get the medication in. Well, I've already alluded to a study today that showed that in severe asthma in the emerge with very low compromised FEV1, there was a better response from using the terbutaline MDI inhaler. The world really changed when Spiriva came along for COPD. We're not talking about COPD tonight, but we used to use Atrovent 2, 4, 6, 8 puffs 4 times a day, blah, blah, blah. A lot of patients, and I had one colleague particularly, never used a dry powder inhaler for a COPD patient, particularly a severe patient, because she never believed they could get it into them. Within 3 months of Spiriva hand inhaler, which is not the best of all devices coming on the market, she was the highest prescriber in the province. And when I asked her about that, she said, well, it works. So again, there are perceptions, there are realities, whatever. And there used to be a lot of medications came and they talked about particle size and delivery efficiency and this and that and the other. To be honest, I think COPD patients have more chronic airflow limitation on a day-to-day basis, and the dry powders seem to have overtaken that field for acute or chronic management. So I think that's the easiest way to accept it. In clinical trials, usually all patients, no matter what the device, must be shown how to use the device, must demonstrate they're able to use it, and that's the thing that we do encourage. The number of people I have that have been prescribed devices and have no idea how to use them, and I do, it's sometimes I go through with the residents, every fellow, I do a session. Some people think it's a bit Mickey Mouse, but I do a demonstration of every single device out there. And even at Grand Rounds last year, I tossed out 2 balls and had someone open a box and load a Spiriva Respimat, and then someone else demonstrate how to use that Spiriva Respimat, and the audience was not good.
Great, thank you. So our last question is, would you speculate that the slight advantage of scheduled and PRN Symbicort versus PRN use would disappear in a more pragmatic trial?
Well, in real life situations, I think people by definition with asthma are probably more sigma patients than they are smart patients, if you know what I mean. I think the patients with more established disease will use it regularly. It's very hard, you know, to remember to take medications on a regular basis, particularly if you don't have the symptoms. And I'm sure you guys see that all the time in pharmacy or whatever. Even, you know, that's where a lot of us have moved to short course treatment, and some of it may be, and that's the commonest essays we used to get. You know, what's the difference between once a day and 3 times a day? What is the advantages and disadvantages of combination drugs compared to you know, separate individual doses? Again, that's sort of motherhood statements. So I think patients will do what they want. We now have evidence from the evolution of SMART, Symbicort twice a day plus PRN, even the use of Symbicort Sigma PRN, that patients can benefit from this. That if they start to pick up just their inhaled steroid, it's going to take a little bit of time to kick in, and if they're constantly overusing their Ventolin, it's doing them no good for their underlying asthma. So I constantly will tell my patients, Ventolin is not a treatment for asthma, and some of them get very taken aback for that. And by treatment, I mean something that is disease modifying or treats the inflammation, and Ventolin does not do that. So I think it's easier to answer it in that roundabout way. And I think we are looking, you know, many years ago, I published a couple of real life studies. Maybe 20 years ago, we published 3 real life studies of adding singular into regimes of asthma and allergy, and showed a benefit. And they were very heavily criticized because they weren't randomized controlled trials. I said, well, this is what happens in real life. You know, this shows a benefit, and there are lots of reasons behind that. So we need to study how to look at real life outcomes a little bit better. And now we are very cognizant of what we call PROs, patient-reported outcomes. But I think anytime you in the pharmacy world can help us, whether it's a poster, a leaflet, or demonstrating something to patients, it's really important.
Great, and that's all of our questions, and thank you. And then, so I would like to thank once again to our event sponsor, AstraZeneca, as well as Dr. McIver for taking the time to share your knowledge and experience with us. And hopefully you all found this webinar really helpful. And then we'll be sending out a short survey afterwards to get some feedback from you. And thank you once again, and good night.
Oh, thank you all very much. And the feedback's important because hopefully we can do more of these in the fall. But thank you very much, and have a really nice night, and stay safe. Bye-bye.
Bye.